comparing to those maternal diabetes is only 7%. Family history is 4%. So this is the one of the most important indication. And this indication, when you have a strong obstetric sonographer, they screen the mother, they will detect these indication and they will to improve the detection of congenital heart disease. This is another statement, scientific statement from the American Heart Association. Actually, just to show you the current practice of fetal cardiac medicine, this is been published in 2014. Actually, this is one of the very nice review. I recommend anyone who doing a fetal echo is to review it. It give you a full review of all the fetal cardiac abnormality. It's the indication of fetal echo. We go through it one by one. Again, the leading reason for referral of fetal cardiac abnormality is suspicion of a structural heart abnormality on obstetric ultrasound. That's why important to have a proper antenatal heart assessment for all the pregnant ladies. Just we'll go start by the maternal factors or maternal indication. If you can see here, this is a little bit busy table. There is a maternal factor. We'll go over it one by one. Pre-gestational diabetes, gestational diabetes, phenylketonuria, autoimmune disorders, maternal indications, maternal exposures, maternal infections. All these will go one by one over it. Let's start by maternal pre-gestational diabetes. Pre-gestational diabetes, when usually gestational diabetes, if we start by gestational diabetes, the risk is only 1%. So whenever any mother with gestational diabetes is not indicated for fetal echocardiography. But however, they would check the hemoglobin A1C. When the hemoglobin C more than 6, fetal echo in the third trimester is considered to be referred. When we go to the pre-gestational diabetes, this is the risk. They have an absolute risk of around 3 to 5%. So any mother with pre-gestational diabetes, they have a risk of 3 to 5% to have a congenital heart disease. And actually, the risk is little bit specific to some sort of congenital heart disease, like those with heterotaxia, truncus arteriosus, especially transposition of a great artery. I have two mothers where the pre-gestational diabetes, both of them, they have actually transposition of TGA. That's why it's very important, the awareness of these mothers to control their diabetes before they get pregnant. Phenylketonuria is not that common. However, still it's common a little bit in our eastern province. It carry a very high risk, 12 to 14%. And the risk will be more higher if the phenylalanine level is more than 10 milligram per deciliter. And usually it's come in the family, so you need to risk and detail in the history about the mother if they have phenylketonuria. Anti-autoimmune, in general, still it's a carry risk to 1 to 5%, especially lupus, Sjogren's syndrome, especially those mothers being screened to have anti-Ro or anti-La or SSA or SSP autoantibody. When it is positive, the risk is 1 to 5%. And the most important thing here is the risk of those mothers is higher when it is associated with hypothyroidism or vitamin D deficiency. All of us, we have vitamin D deficiency. So please screen those mothers for vitamin D and hypothyroidism. Whenever we have those associated with, the risk will be more higher. And they have recent study, they suggest that, again, the value of these autoantibody, when it is more than 50, it's correlate with, again, increased fetal risk of, we'll talk about it like complete heart block, arrhythmia problem. Another important thing for these mother, which is important in the history, you have to ask the mother when they have a prior baby affected with complete heart block. Mother, she's autoimmune. However, she came to you to the regular clinic. However, she had a previous baby with complete heart. You need to dig detail in the history about this because the risk here will be more higher, reach about 20% whenever if the mother have a previous baby with complete heart block or have a neonatal lupus. And those mothers usually screen them early at 16 weeks, and they continue to screen them up to 28-week gestation. Maternal medication, as a general, it's a lot. However, the most important things, as I said, any risk more than 3%, it's indicated for fetal echo. The most important things medication is AC inhibitor. Still, the risk is high. Retinoic acid is 8 to 20%, which is very important. Vitamin A is not. Retinoic acid is an active part of vitamin A. Vitamin A is contain retinol and other things. However, retinoic acid is carry more very high risk of 8 to 20%, especially those mother was using some creams and these things. Again, the history is very important for them. Antidepressant medications is not that of a high risk. Still the risk between 1 to 2%, especially for the medication like paroxetine. Initially in the previous guideline, they said it's indicated. However, in the recent guideline, they say it is not, might be considered. Vitamin K, warfarin is not indicated for fetal echocardiography. However, warfarin can associated with extracardiac abnormalities. Non-steroidal anti-inflammatory like Profen, Voltaren, all of this, it's carry a risk of 1 to 2%. However, we need to check if the mother, especially in the late gestation, whenever they have a ductal constriction, they carry around 50%, especially when they use these medication in the third trimester. They may have some ductal constriction. I might progress to right-sided failure. And I will show you one of these cases with ductal constriction when we talk about fetal heart failure. Maternal infection in general, rubella. Rubella is the only one is associated with congenital heart disease. Still, the risk is a little bit 1 to 2%. User-assisted reproductive technology is, again, several guidelines, they say is not indicated. The recent one, they said it's indicated. All the, it's between 1.1 to 3.3. both IVF oral ICSCV اللي هو cytoplasmic whatever type of reproductive technology. Okay, they said the risk still might be considered between 1.1 to 3.3%. If we talk about the family history, we finished the maternal history factors. The family factors, in general, as all we know, mother with congenital heart disease is considered a very high risk, 3 to 7%. Any mother with congenital heart disease, you need to be referred to fetal echocardiography, especially those mother with a single, especially if she had any single ventricles, whatever, we'll talk about it later on. They carry a risk about 3 to 7%, especially if she had ABSD or aortic stenosis, citrology of follow those, they carry a very high risk, especially AV canal, 10 to 14%. The paternal structure is only 2 to 3%. However, I think we have a lot of cases being missed because nobody asked, is the father have any problem? Most of the time, we mainly concentrate on the mother or don't concentrate on the father. Some of the report about 7.5% whenever the father. So again, you need to dig in the history regarding if the father had any congenital heart disease. Sibling with structural heart disease, especially if they have hypoplastic left heart syndrome, still the risk is 3% and is indicated for fetal echocardiography. The risk to have the exact lesion, what we said, exact concordance, around 20 to 35%. However, different lesion is around 50, less than 50%. So some of them, they have the same lesions, actually. Second degree relative with structural heart disease is not indicated. So no need to refer. Again, third degree relative with the structural heart disease is not. So second with third degree, no need to refer for fetal echo. However, when we have a first or second degree relative, with disease or syndrome, they have a very high risk of 50%. So again, the history is very important to ask if the family, if they have any chromosomal abnormality, is still the risk and it still is indicated for fetal echocardiography. Fetal factor, which is the most important factor, all of anything in the fetus, you have to refer it, especially when you have the most important referral, which is when you have a suspected cardiac abnormality during routine obstetric ultrasound. That means more than 40% the risk to have a congenital heart disease whenever you suspect any abnormality. Rhythm abnormality in general, tachycardia, brady, or irregular, this is need to be referred on the same day. Non-cardiac abnormality, we'll talk about it again, and other chromosomal abnormality. if you talk about an extracardiac abnormality, as we said, 20 to 45%, and the percentage depending on the organ that's been involved. And the most important organ to be associated with congenital heart disease, when you have a genitourinary abnormality, the risk around 71%. Other CNS, congenital diaphragmatic hernia, duodenal atresia, omphalocele, all of this can be still have a risk of congenital heart disease, and you need to refer. Fetal abnormality, there is the abnormality, and we'll talk about it in the coming lecture. Whenever you have a fetal, either tachy or brady or irregular rhythm, you are not sure is it benign irregular rhythm, you need to refer it actually in the same day for pediatric cardiology, because any fetal with height, especially they might progress quickly to fetal hydrops. So any fetal hydrops fetalis, still they have a very high risk, 15 to 25%. Congenital heart disease need to be ruled out whenever you have a hydrops fetalis. Abnormality in the umbilical or placental or intra-abdominal venous anatomy is around 3.9%. Still carry little bit risk. NT thickness, which is very important. NT thickness is, as all we know, it is a subcutaneous fluid. It's accumulates behind the cervical spine, actually, in the first trimester. Usually the lymphatic system is mainly drained to the veins, jugular veins. And whenever you have excessive fetal fluid, it appears at like a visible or subcutaneous fluid accumulation in this region. It's mainly during the first trimester. After the first trimester, the lymphatic system starts to develop, and actually it may undergo some further development, and these accumulation of the fluid, it will be resolved. So this is the period you need to assess and to look for these, because it carry a risk with congenital heart disease. It has specific maneuver. Actually, as a pediatric cardiology, we are not get used to do it. Most of our colleague in our obstetric ultrasound, they know how to do it and how they measure it. Usually the cut off the 99th percentile is 3.5 millimeter. Wherever you have an NT thickness more than 3.5 millimeter, the risk of congenital heart disease is very high. So even if you have normal increased NT thickness with a normal fetal karyotype, even the fetal karyotype is normal, still the risk with congenital heart disease is high. So whenever you have a higher NT thickness, the risk will be again higher. There is a lot of, if you go through the literature, there are a lot of publications they are talking about it. Whenever you have a high NT thickness, the risk of congenital heart disease is high. But the cut at 99% is at more than 3.5. If you are, some of the department, they take it more than 3. But usually most of in the literature, 3.5 is indicated for fetal echo. Another one indication, whenever you have a fetus with a reverse flow in the ductus venosus, especially in those with enlarged NT thickness, usually you have to check the ductus venosus. Usually the ductus venosus is, as all you know, it is a continuation between the umbilical vein and the IVC, inferior vena cava. It's act like a valve to control the blood coming from the umbilical vein, and this blood should be continuous, systole, diastole, and continuation of the flow. Never return back to the baseline, never be reversed, because all of this blood is going directly to the heart. Whenever you have reverse flow of the ductus venosus, like in this picture, especially in the first trimester, and you have high NT thickness, this is the risk of congenital heart disease. You suspect it will be very high. Monochorionic twins, in general, especially the monochorionic twins, they have high risk for congenital heart disease, more than diachronic twins. Monochorionic twins, the risk around 2 to 9%, so indicated to refer for fetal echo. And usually the problem that, especially when they have twin-twin transfusion, they associated with polyhydramnios and sometimes myocardial changes in the recipient twin. So you need to refer this as soon as possible whenever those monochorionic twins, they have twin-twin transfusion. Intracardiac or echogenic foci, it is a soft marker, no more not indicated for fetal echo. It's considered as a calcification of some of the papillary muscle. It can be single or it can be multiple. Can be in one ventricle on the left, it can be in the right side. So whenever you have a single or multiple echogenic foci, it's not indicated. The most important in those fetuses with echogenic foci, you need to screening like the usual screening. The most important thing is you need to rule out cardiac tumor. Be sure that it is a really echogenic foci, is not a cardiac tumor. And you can see the echogenic foci, it's around, very clear, like a golf ball. We call it like a golf ball, and it is mainly in the papillary muscles. You need to be sure it's not cardiac masses or rhabdomyoma or a significant little bit. Like I see this case, it's like a echogenic foci. However, the calcification, it's extend more further rather than this is can consider a golf ball. However, these calcification a little bit more. So I follow this patient actually postnatally, and it turned to be some like little bit muscle and considered to be rhabdomyoma. So whenever you have echogenic foci, you need to be sure it is not a rhabdomyoma or not a cardiac tumors, and you need to follow it actually. So in general, common indication for referral for fetal echocardiography is whenever you have a higher risk, estimate more than 2% absolute risk. As we mentioned, maternal pregestational diabetes, diabetes diagnosed in the first trimester, maternal phenylketonuria, maternal autoantibody, maternal medication like an ACE inhibitor, retinoic acid, non-steroidal anti-inflammatory medication in the third trimester. Maternal first trimester rubella infection, maternal infection with suspicion of fetal myocarditis, if a fetal myocarditis been involved, function being involved, this is you need to refer it. Assisted reproductive technology, congenital heart disease, the first degree relative of fetus, maternal, paternal, or sibling, first or second degree relative with the disorder or with Mendelian inheritance with congenital heart disease association, and this is considered to be referred. That's why the history is very important in this mother. Fetal cardiac abnormality suspected on obstetric ultrasound, fetal extracardiac abnormality suspected again on obstetric ultrasound, fetal karyotype abnormality, arrhythmia in general, fetal NT thickness more than 3, problem they said more than 3.5, monochorionic twinning and fetal hydrops or effusion. This is indicated in most all of the guidelines. They said it's indicated for fetal echo. Other less than 2% or more than 1%, it might consider, which is depend on your institution or your department itself. Some of the department, they think they have very expert obstetric sonographer. They don't refer these. They just refer for only fetal abnormalities in fetal heart. So you have to weigh how is the experience of your obstetric sonographer in screening the fetal heart. So between more than 1% to 2%, the risk is very low. For example, like anticonvulsant, lithium, vitamin A, some of the antidepressant medication, non-steroidal in the first or second trimester, congenital heart disease second degree, fetal abnormality of umbilical cord and placenta, or fetal intra-abdominal venous abnormality. The one dose with not indicated, اللي هم less than 1%, اللي هي maternal gestational diabetes, maternal medication, برضو زي الفيتامين K والmaternal infection other than the rubella with seroconvergent and isolated congenital heart disease relative other than the first or second degree. So again, it depends on your department itself and the experience of the one who's doing the fetal screening to go over this indication. Some of the areas I mentioned is just go for, they have very experts and they refer whenever you have whenever have a fetal abnormality in the heart. This is a review between all the guidelines. This is a recent guideline in 2023. As you can see, they are almost the same. There is no much difference in the recent guideline and in the American Heart in 2014. So it's almost the same, no change in it. So in general, majority of the baby with congenital heart disease are born to a mother with no identifiable risk factor. What does this mean? This means that I need to screen all the pregnant mother is the same, because most of the mother with congenital heart disease actually the baby with congenital heart disease actually delivered to a mother with very low risk factor. So again, the leading reason for referral for fetal cardiac evaluation is suspicion of structural heart abnormality in obstetric ultrasound. That's why you have to improve the skill in our obstetric scanning for routine fetal heart scanning, and to have a high quality screening OB ultrasound will be able to detect the congenital heart disease. Thank you very much.
Thank you very much, Dr. Amirna. Very informative and really comprehensive review of the indication. So please, if you have any question, we'll leave it to the end. And I'm sure there'll be a lot of questions about the indication. So please note down your questions will be answered at the end. And I would like to remind you, inshallah, this presentation will be recorded and we'll post it at the YouTube channel of the USWAG Oman. This is the second fetal cardiac webinar. So all that the presentations will be in the YouTube, inshallah, in coming weeks. Thank you, Dr. Mena. So I'll share my presentation, Zakiya.
الديسكتوب مالك الحين على الشاشة دكتورة.
نعم، بس أحط البرزنتيشن نفسها. البرزنتيشن ظاهرة؟
أيوة ظاهرة، بس حطيها برزنتيشن سلايد شو.
طيب خبريني بس إذا واضحة. ظاهرة؟
أيوة واضحة الحين دكتورة.
طيب. بسم الله الرحمن الرحيم. So the second presentation will be about the basic views to scan the heart. I'm sure all of you, this will be like a repeated lecture, but it's also good to hear it again. So a little bit, I'll be talking about the fetal circulation and then about the screening done by fetal cardiologists, because our technique is a little bit different from fetal-maternal colleagues. In the screening part, I'll be talking about how to determine the right and left side of the fetus, the cardiac position and the cardiac axis, and then the basic views, and finally the checklist. So congenital heart disease is the most common congenital anomaly found in the human. That's why a detailed fetal exam is mandatory in order to complete and make an accurate diagnosis. At 18 weeks of gestation, the fetal heart almost resembles the old 25 Omani Beza, if you remember it. Now, when we do the fetal cardiac scan, we are using the approach which is called segmental approach, which means that we are defining the heart into connections. And then we define these connections with the segments. So you have the segments like the atria, the ventricle, and then you know what are the inlet and the outlet, so that you will not be missing the diagnosis, because there are a variety of congenital heart disease. And using this segmental approach and the standard screening is very important in order to get the accurate diagnosis. Now, regarding the fetal circulation, as you know, the placenta is the main oxygenator for the fetus. So the oxygenated blood will be coming from the placenta through the umbilical vein, which will go through the liver, and then it will join the ductus venosus. And here at the level of the liver and join the IVC. From there, the blood will go to the right atrium. Part of the blood, or majority of it, will cross to the left side of the heart through the foramen ovale, and then to the left side, left atrium, left ventricle, aorta, and then to the body. The other part will go through the tricuspid valve, right ventricle, and then pulmonary, ductus arteriosus, and then back to the descending aorta. We'll take again the deoxygenated blood through the two umbilical arteries back to the placenta for oxygenation again. When we talk about the fetal circulation, we need to know about the three important things: the ductus venosus, which Dr. Mena talked about, ductus arteriosus, and the foramen ovale. So ductus venosus, this is a venous connection between the umbilical vein to the IVC. when you put the fetus in sagittal plane, like in this view, you will see the ductus venosus, or when you put the fetus like in a cross section, just below the diaphragm, you will see it. And ductus venosus, as Dr. Mirna mentioned, it acts like a sphincter where the oxygenated blood, not all of it will come back like a gush into the heart. Otherwise, this will cause high drops in the fetus. So the amount of the blood entering the heart will be controlled through this important channel, the ductus venosus. Foramen ovale. So foramen ovale is an important structure in the fetal heart. To say the heart is normal, they have to have the foramen ovale, which will be the future ASD secundum. So when we see in the report, we mentioned foramen ovale or postnatal ASD secundum, this is like normal in the fetal heart. And the shunt in the fetal heart, you need to know that it's from the right side of the heart to the left. So from right atrium to the left atrium. If it is from left to right, then this is abnormal. And if it is left to right, it indicates that there is left side obstruction, where there is the left atrial pressure is higher than the right atrial pressure, indicating left side obstruction, whether aortic stenosis, coarctation, hypoplastic left heart. So this is very, very important to know. And the circulatory flow pattern in the fetus, as I mentioned, it is right to left shunt or right to left direction, opposite to what is seen in postnatal life, which is left to right shunt. The third important structure in fetal heart is the ductus arteriosus. And ductus arteriosus, this is the continuation of the pulmonary artery. When it joins the descending aorta, it is through the ductus arteriosus. Overall, the normal velocity when we do Doppler, it should be less than 100 centimeter per second. This is in most of the blood vessels in the heart. For the ductus arteriosus, if the peak velocity more than 140, the peak systolic velocity more than 40, then this is abnormal. So it should be less than 140 centimeter per second. If it is high and the flow is not laminar, then suspect ductal constriction for the big systolic. And the systolic, if it is more than 20, 30, 40, then this is again abnormal. And these babies will be born like for pulmonary hypertension. There'll be tricuspid regurg. One of the reasons of ductal constriction is if the mother is taking non-steroidal, whether aspirin, Brufen, or paracetamol. So this can cause ductal constriction, even sometimes right side failure. But once it is the cause is stopped, then it is reversible. Now we'll go to the screening part. For fetal echo done by cardiologists, we are using what is called Cordis method. The beautiful thing about this, you don't need to know where is the marker in the probe, like the technique used by our colleagues, the feto-maternal, or using the thumb sign. So all what you need is to put the fetus in sagittal plane, like in this view, and it doesn't matter where is the spine, whether it is down or up. But the important thing is that the head of the fetus should be on the right side of the screen. If the head is in this position, you have to rotate your probe 180 degrees in order to put it on the right side of the screen. So after you put it in on the right side, then 90-degree clockwise rotation, you have to rotate the probe in order to get one of these four diagrams in this cartoon. And this will be the spine, and the right side of the fetus will be before the left side of the fetus. I'll show you one example just now. For example, here now, the head is in this view. This is the rest of the body. So only 90-degree clockwise rotation to put it in a cross section. Okay, beautiful. So this is the spine. This is posterior. Now this is anterior. This resembles this one. So here is the spine, and the right side, which will be all this, will be here. So the right is before the left. So all this will be the right side of the fetus, and all this will be the left side of the fetus. And this is the stomach bubble on the left side. If we see this view, we say it is situs solitus. And actually we'll say that this is the right side of the fetus and the left side of the fetus, not the heart. Still, I'm not talking about the heart. It's about the right side and left side of the fetus. This is, we call it fetal laterality. And this is very important because here you will see where is the stomach on the left, liver on the right. You see then the heart, the apex to the left. Now we'll talk about the cardiac position and the axis. As you know that the normal heart lies in the left side of the chest and the apex is pointing to the left. The cardiac shadow occupies 30 to 35% of the whole chest. It should not be more than this, which is opposite to postnatal, which is about 60 or more than 60%. In order to know the cardiac axis, like in this diagram, so this is the spine. So this is posterior, this is anterior. You need to get two lines. One line will get it. So from the spine all the way to the anterior part of the chest, and the other line has to go through the interventricular septum. The cardiac axis will be here, and it should be around 45 plus minus 15 to 20 degree, like here. So here is the heart. You take a line, so from here all the way to the anterior part, and this one all the way from the spine, which resembles like this one, all the way to the anterior part of the chest, and the other line passing through the septum, like here. This will be the angle. If this angle is too much to the right side or too much to the left side, then we here, if to the right, we'll call it right axis deviation, or to this left side, we call it left axis deviation. And there are a variety of congenital heart disease associated with the left axis deviation or right axis deviation. And mashallah, I noticed my colleagues in fetal maternal, they really appreciate when there is deviation in the cardiac axis. Then we move to the basic view. They are around 6 to 7. So we have the upper abdomen, we have the four-chamber view, then we have the outflow tracts, which are two: the left ventricular outflow tract, the right ventricular outflow tract, then the three-vessel trachea view, and then the two arches, the ductal arch and the aortic arch. So there are 7 basic views to scan the fetal heart. We'll start with the upper abdomen. So after obtaining and using the Cordis method, or the method used by our colleague feto-maternal, after identifying the right side of the fetus and left side of the fetus, and you already know that the stomach is on the left and liver on the right, you have to be very careful. So this is the spine. Then the structure which is, or the vessel which is very close to the spine, has to be the aorta. So aorta will be posterior and to the left, IVC will be anterior to the right. When we see this picture, then we say it is situs solitus and normal arrangement. And you have to have one complete rib. There should be no like fragmented ribs in order to get really clear diagnosis. Say, for example, if the IVC, instead of being on the right, is on the left, and the aorta is on the right, then this is not situs solitus. This is, we call it situs inversus. Or if you see a vessel behind the aorta and it is more close to the spine, then this goes with what is called heterotaxy or isomerism. And usually with the left isomerism, there'll be a vessel behind to aorta. Now moving to the four-chamber view. When we scan the heart, it's very important to do 2D and then combine it with the color. So in the four-chamber view, first of all, as I mentioned again and emphasize, it has to be one complete rib. So let it run. This is now by 2D. So already we identified the situs, we identified that the apex is to the left, so situs solitus, liver cardia, we identified the stomach. And now moving inside the heart. For the, to identify the atria, so the left atrium has to have the 2 atria. In the fetus, enough to see 2 pulmonary veins by 2D and color. By 2D, you will see that there are invaginations. So this will be the left atrium, while the right atrium will be blunt. You will see also in the atria that the foramen ovale is bowing to the left atrium. So this will differentiate between the left atrium and right atrium. Now for the ventricles, it's important to know that before 28, 30 weeks, the right ventricle and left ventricle are symmetrical, but after that, the right ventricle will be dominant. Now, after you identify the right side of the fetus and left side fetus, some cases, the right ventricle will not be on the right and left ventricle will not be on the left. So it's very important to know the feature of every ventricle. And you need to know that the ventricle follows the valve. Even if the ventricle position is, for example, even if the right ventricle position is not on the right side of the fetus, because there are some conditions, the right ventricle is on the left. But knowing the feature of the ventricle will make you to know which ventricle is on the right and on the left. And I found it mainly by knowing the AV valve, the feature of tricuspid valve and the mitral valve. Once you identify the AV valves, then identify the corresponding ventricle. So let us see. Now, for the valve which is on the right side, like for example, this valve. Now, this valve, compared with the other valve, there is, let it run again. Okay, I hope it is clear. So this valve, this leaflet, which is the septal leaflet, it's very close to the septum, while the other valve is away from the septum. And the valve which is close to the septum, we call it septophilic. Septophilic, this is the tricuspid valve. The valve which is away from the septum, that will be the mitral. And very important to appreciate what's called the offsetting feature of both AV valves. So they are not at the same level, the tricuspid and the mitral. The tricuspid is somehow apically placed, while the mitral is little bit up. So by identifying this, so again, this is the tricuspid valve very close to the septum, while the mitral is away. Then if this is tricuspid valve, this ventricle has to be the right ventricle, because we say the ventricle follows the valve. This is the first feature. Second feature, the right ventricle will be heavily trabeculated and there is a moderator band, while the left ventricle is smooth. Right ventricle has 3 papillary muscle and has the chordae tendineae attached to the wall, while the left ventricle only 2 papillary muscle. After 2D, then we'll put the color. It has to be laminar. If it is not laminar or aliasing, then there will be regurgitation. Then we look for if there is any pericardial effusion. It has to be less than 4 millimeter, and that will be physiological. And then to look for the squeezing pattern of the fetal heart to say it's like normal contraction, and then counting the fetal heart rate, which should be more than 100, 100, and less than 180. Dr. Mirna will talk about it in her presentation, inshallah, about the arrhythmia. So here again about the 4-chamber view, you can get this view where the ultrasound beam is parallel to the septum, or the ultrasound here will be perpendicular. And this view is very good to detect if there is any VSD. So for example here, 2D and color, even if with 2D it's not clear, but here you can appreciate that there is VSD. So there is muscular VSD. And I want to emphasize that in the fetus, usually we don't measure because it is not accurate, the size, and it will be changing. So just we tell the mother small or moderate or large VSD, but we don't really measure and give exact size. You need to know that the shunt through the VSD in fetal heart is bidirectional because the pressure in the right ventricle and left ventricle are equal. And usually when it is small, I reassure the lady that most of the time it will close spontaneously. This is then another view, but in this fetus, there is a perimembranous VSD. Single ventricle from 4-chamber view also, and my colleague, mashallah, from fetal-maternal as early as 16 weeks and sometimes earlier than this, they appreciate it because of the ventricular discrepancy in size. So for example, this fetus with hypoplastic right heart and this fetus with hypoplastic left ventricle. We mentioned about that in normal heart, there should be offsetting where the tricuspid valve level should be lower a little bit than the mitral. But in this heart, I hope you can appreciate it, there is no offsetting. So both AV valves, the right and left AV valve at the same level. When you see it like this, this means that the crux is not intact. And this is the area is the crux. So if the crux is not intact, you need to think about what's called ASD primum. In this fetus, there is no offsetting and crux not intact. So there is ASD primum plus there is a VSD. So this is an AVSD. And we need to know that 50% of cases with AVSD can be associated with Down syndrome. After the 4-chamber view, we move to the outflow tracts. So left ventricular outflow tract, we need to know that here the aorta is coming exclusively from the left ventricle. And it's very important to know that there is slight angle. So this is the apex, this is the LV, and this is the aorta, and this is the septum. So when you go a little bit up in the septum, there is slight angle from the septum to the ascending aorta. This angle is very, very important because if you don't see this angle, think that there is a defect here, like aortic override, because here you don't see that angle. This means that this area is not intact, like what you see here. So the aorta here only coming from the LV, while here the aorta mild from like 50% from the right ventricle and 50% in left ventricle. And here you need to suspect conotruncal, like tetralogy of Fallot, or double outlet right ventricle, or pulmonary atresia. So pay attention whenever you are doing the outflow tract that there is this angle, if it is there or no. Again, about the left ventricle outflow tract. So this is the spine, then this is posterior, this is anterior. So this is anterior ventricle. Usually, or maybe 99%, the right ventricle is anterior and the left ventricle is posterior. You can see here that this posterior ventricle is branching. If this is the left ventricle, why then it will be branching? Then this is not aorta, this is pulmonary. Plus they are parallel great arteries. Then we are dealing with TGA. So it's very important to get the outflow tract. If you do only the 4-chamber view, you can detect up to 40 to 50% of congenital heart disease. But if you add the outflow tract, the detection or sensitivity to pick up cardiac condition will be up to 70%. Then right ventricular outflow tract, where you will see the aorta. So this is the left ventricle, and then surrounded by the pulmonary. So this is the aorta, and it's wrapped by the RVOT, right ventricular outflow tract. And in this fetus, small pulmonary valve and small pulmonary artery branches. This is a case of tetralogy of Fallot, and very important to pay attention to the crossing nature of the both outflow tracts. If there is no crossing nature, then think, and they are parallel, always think about TGA. This is the most important condition to be diagnosed antenatally, because these babies will be very blue, and at the end it is repairable and very good result, and will be normal circulation if picked up earlier. Otherwise, if really not picked up, the baby will be cyanotic and they can die. That's why 4-chamber alone is not enough, so we have to do the outflow tracts. Now, after the LVOT and RVOT, we move a little bit up to what's called the 3-vessel trachea view. So this is the spine posterior, here anterior. So the pulmonary, here with color, the pulmonary trunk will continue as ductal arch, the aorta will continue as transverse arch, and they will join together at the descending aorta, forming the V sign. And this is the SVC. The arrangement has to be pulmonary, aorta, SVC, and they should be almost equal in size till 28, 30 weeks. After that, little bit, the ductal will be bigger than the aorta, but they should have forward flow, and there should be no flow reversal. If you see another vessel here to the left of pulmonary, then this patient is having left SVC, and this structure is the trachea. In 3-vessel view, in addition to recognizing the 3 vessels, you will see anteriorly the thymus. So if you don't see the thymus, then suspect that this patient is having DiGeorge or 22q11 micro deletion. So by doing the 3-vessel view, you can rule out all these conditions: the aortic stenosis, the pulmonary stenosis, the TGA, truncus. I will show you now some videos: hypoplastic left heart, the vascular ring, which Aisha will be talking about, interrupted arch, and tetralogy of Fallot. This is a busy slide, but good to know. So the first case about a fetus with bilateral SVC. I hope the view is clear. These are all about 3-vessel view. So in this fetus, instead of having 3 vessels, there are 4 vessels. Here, the pulmonary, there should be no adjacent vessel to the pulmonary. If there is adjacent vessel, then this is left SVC. And if there is bilateral SVC, so sometimes it can be associated with congenital heart disease like coarctation. But when we do the scan, if there is no associated congenital heart disease, then we need really to reassure the mother and not to be anxious. So we'll tell her this is like a variant, and in your fetus, there is no congenital heart disease, but this is after really doing complete fetal echo. So if you see bilateral SVC with no congenital heart disease, just reassure the mother and no need for referral. Then the second case is about right aortic arch, the C shape or the U shape. In this fetus, you can see here the aorta and the so this is posterior, anterior. This is the ductal arch, and this is only the transverse arch. See how small it is. So this can be seen either in coarctation, severe coarctation, or in hypoplastic left heart. When you don't see the transverse arch continuing into the descending aorta, then it is interrupted. So this is pulmonary continuing as ductal. This is the transverse, but it is not continuing, and this is the SVC. See it again. Then here, if the transverse is not going to join the descending, then this is interrupted arch. While here, it will be tapering small hypoplastic in the hypoblast and the severe coarctation. In TGA, because in TGA, the aorta coming from RV, which is anterior, so aorta will be to the anterior and pulmonary will be posterior. So you will see this view, aorta and pulmonary posterior. This is in TGA. In tetralogy of Fallot, when you do the 3-vessel view, you will see that the pulmonary is really smaller than the aorta. Now we move to the last part, the arches. We have the aortic arch and the ductal arch. So the aortic arch will come from the middle part of the chest, and it has short course, and then it will continue as descending aorta and will give head and neck vessels. It's called, the appearance is like candy cane appearance, while the ductal arch from anterior part of the chest, long course, and it doesn't give head and neck vessels, and it has the appearance of the hockey stick appearance. Both the aorta ductal arch and aortic arch, you will not see them in the same plane. So for the aortic arch, different plane, ductal arch, different plane. If you see together, again, think about TGA because they are parallel. And it should be forward flow. There should be no flow reversal. If there is flow reversal, indicates there is obstruction. Then bicaval view, the superior vena cava and the inferior vena cava. Now we move to the last part, the checklist. We spoke about the situs, the upper abdomen, when we talk about the liver, stomach, IVC, and aorta. We talked about the in-4-chamber view, about the heart, where is the position, the axis, and the things to look at. The rhythm should be normal, squeezing of the heart, and minimal pericardial effusion. 4-chamber view, you can exclude if there is, for example, situs abnormality, if the heart is outside the chest, single ventricle, AVSD, or the pericardial effusion amount is not physiological. Then from outflow tract, you will need to see the crossing nature and there is no VSD. So when you add the 3-vessel view to the outflow tract, so you increase the sensitivity from 70% to 95%. And 3-vessel view, you look at the number, arrangement, and size, both arches, trachea, and branch pulmonary arteries. And as I said, both arches, the features of each one, and the flow direction should be forward and no flow reversal. That's the end of my presentation. And if any question, I'm happy to answer at the end of the webinar. Thank you. زكية.
هاي دكتورة، بس الحين ستوب شيرنج عشان الدكتورة اللي بعدك تسوي برزنتينج.
طيب.
أنا أسوي الحين.
أيوة. So now Dr. Aisha will be talking about the vascular ring. Also, this is very interesting and so many, mashallah, referrals about right aortic arch and vascular ring. Very interesting lecture. Go ahead, Aisha.
السلام عليكم ورحمة الله وبركاته. I hope you are happy this evening and interesting lectures. So vascular ring is very important, and aortic arch sidedness is the one which most of the time referral may come. And in this presentation, I would like to talk about the understanding of what is this arch sidedness, and to help you recognize abnormalities in the arch and practical points, recognize the vascular ring. And in order to study about it, we need to know what is the normal arch. Actually, most of the arches are left-sided, and it has a 3 major branching. That's how you differentiate between the aortic arch and the ductal arch, by the branching of the neck vessel branching. So you have a brachiocephalic, and then you have the left carotid, common carotid, and the left subclavian artery.
Aisha?
Huh?
And
Yes.
I don't see the presentation. Zakiya, do you see the presentation?
دكتورة واضح على الشاشة، ممتاز.
ما أدري ليش ما يظهر لي. أوكي. يمكن عندي أنا مشكلة.
And then
كملي دكتورة.
okay. Then we have to look for the axial view of the aortic arch. The technique of that is you should get a good 4-chamber view, then angulate your probe towards the fetal head. And in here, you get either 3-vessel view. If you go more higher up, you may get the 2-vessel view. So in these views, we look to the structure, sizes, number, and the color, direction of the flow. And each one of us, we should keep a checklist, and usually this is what we do. So we look to the number of the vessels. We should have 3 vessels, the pulmonary artery, which is anterior, and then aorta, which is in the middle, and the superior vena cava. The flow direction should be of the same flow, and the sizes also, the pulmonary artery is bigger and larger than aorta, and the aorta is larger than the superior vena cava. So when you go higher towards the head of the fetus, you get the ductal arch and the aortic arch. Here also we look to the size and the flow, and you get the V-shaped in this view. So this is the ductal arch, and this is the aortic arch in the middle, and the superior vena cava. If you look towards the anterior to the vertebra, you get the trachea, and which will be blended area. The sizes, the color, the flow of the color, all will be very clear if you do that 2D and color at the same time. And you compare the sizes to 3. So you have here 3 vessels. You may have 4, another superior vena cava on the right side, and you have one on the right side, and you have another one on the left side. And you may get either one of the great arteries maybe, or ducts may be smaller than the other one, which indicates diseases like pulmonary stenosis or aortic stenosis or hypoplasia of the ventricles, because the growth of these vessels actually depend on the flow. So what is the question comes, what is the aortic arch sidedness? This depend on the bronchus that is crossing the arch. So if the left bronchus is the one which is crossing, so this is the left-sided aortic arch, and will lie on the left side of the trachea. If the arch crosses the right bronchus, this is the right aortic arch, hence will be on the right side of the trachea. Like we see here, this is the trachea, and you can see the aortic arch goes towards the left of the trachea. So this is what we call it, a left aortic arch. This is the view that we are looking, the axial view of the arch, and you can see the 3 vessel views. And here is the diagrammatic view of the 3 vessel view. So this is simple to make it simple. What is the left aortic arch? So you can see the left bronchus, and the arch is going above it. So this is the left aortic arch. And when you may have an apparent right subclavian artery or apparent left subclavian artery, depending on so you have a left aortic arch, but the subclavian artery, which should come from the right brachiocephalic, it may come from the descending aorta and cross all the way to the right right arm. Most common, which is the most common, it's around 0.5 to 1%, and rarely cause any complications. So if you see this, you may reassure the family. These patients, when they get older, they may have some dysphagia, but it should not cause any stridor or any other or affect any respiratory. So this is the apparent right subclavian artery, and in this vessel, it goes behind the trachea and in front of behind the arch. So if you find any red vessel going in this area between the trachea and the trachea and the aortic arch, you should think of apparent right subclavian artery. Now about the right-sided aortic arch, you can see here, it's going towards the right. So this is the trachea and it's going towards the right and it will cross the right bronchus.
Aisha,
Mm-hmm.
this is nice of you. Just can you go back?
The slide before?
Yes, please. So here, the V sign is there. The V sign is maintained. You have the ductal arch and the aortic arch. So both on the left side, we have the V sign.
The trachea,
but
yes.
We have this abnormal vessel coming from the aorta, which is apparent.
Yeah, yes. So this is what we call apparent right subclavian artery. It should not cause any major issues to the child, and you can reassure the family. Sometimes some children, they may have dysphagia, but I think it is they can tolerate.
Sorry, Halima and Dr. Aisha, do you hear me?
Yes?
Yes.
Yeah. Can you go back to the previous slide, because this is we do get a lot of referrals, me and Dr. Halima, about apparent right subclavian artery, and the counseling is very important in this case, because when the patients they are coming to us, they're already overwhelmed with the previous counseling that this is associated with Down syndrome. Can you comment on this, Dr. Aisha or Dr. Halima?
No, actually, most of the time it's not in any association with any congenital heart disease, and some we can detect some of these with patients with Down syndrome, but it's not like a stigmata to say it must be there. So you need to reassure the family.
Do we need to refer them to you for echo?
Preferable, especially especially just to get an expert opinion, and at the end to relieve the stress of the family. What do you think, Halima?
Okay, now personally, when I see both the aortic arch and the ductal arch both at the same time, this is not vascular ring, not vascular
Yes.
ring. Yes, because both the aortic arch and ductal arch on the same side. If it is left arch and right arch with the left subclavian, that's something different. But both of them, if they're the same side, usually I don't take the referral for the left arch. And then because of the association with the trisomy 21, it depends not only on this finding. We have to take the patient as a whole. Are there any soft markers hinting toward trisomy 21? If not, then we'll reassure the lady. For example, in my clinic, really, left aortic arch, left ductus, apparent right subclavian artery, usually I reassure and I don't accept in my clinic. This is different from right aortic arch, left ductus, and apparently subclavian or diverticulum of Comeril, as you will show later, Aisha.
عفوا بس دكتورة موزة قصدها الاسوشيشن مع الداون syndrome as isolated apparent right subclavian.
It can be associated, but not we should not just when we see this, for example, I will tell her this is Down syndrome. So it's very important to rule out the other markers. Our colleague in fetal-maternal, they know better than us. For example, if there is anything else suggestive of Down syndrome, we tell, okay, associated, but not necessary to be Down syndrome.
Yeah, I agree with you. It's not necessarily. Some of the reported literature, they report around 15, I'm not aware, 15 to 20%, but it's not 100% sure that it is associated with Down. I agree with you.
Okay, we'll go to the next So now we'll talk about the right-sided aortic arch, and we defined it as the arch crossing the right bronchus, hence on the right side of the trachea, as it is in this diagram. So in most of the cases, right aortic arch, when you don't have any other things, it maintains the same figure as a V-shaped. So and the branches of the left aortic arch, but it crosses to the right side of the trachea. This is rare. It is 0.05% to 0.35%. Easily missed because it is the same configuration as the left aortic arch. There is some association with other congenital heart disease. That's why we need to check very well about the presence of any VSD and presence of the other association like truncus or tetralogy of Fallot. And then the right aortic arch has a course to the right side of the trachea, while the pulmonary artery and the ductus are to the left side of the trachea. At this point, the configuration that we see in the echo changes. Now we get the U shape or the C shape of the arch. So, and in this case, you can see the pulmonary artery in its position, but you look for the aorta, and you will see it is between the trachea and the superior vena cava. So it will be the trachea will be in the middle of the both ductal arch and the aortic arch, like seen here, and more in this configuration, but you don't see any other vessels. So this also, as it is a right aortic arch without any other vessels crossing either in front or crossing in front of the trachea. So this is should not cause any problem to the child, but we should look for other association of congenital heart disease. This is a video. I'll show you the left aortic arch. You can see this is the pulmonary artery on the left. Okay, anterior, and this is the ductal arch. It's the superior vena cava, and here the trachea. So it's going to the left of the trachea. So this is left aortic arch.
Then this is not a vascular ring.
Yeah, this is not a vascular ring. Now the right aortic arch, you can see the configuration actually changed. You can see it's not anymore going sharp V-shaped, but it's crossing and going between the trachea and the pulmonary, the aortic arch is going between the trachea but the shape also changed. So you can see it's like, and the trachea, it is in the middle. This is the trachea. This is the arches. So when you have a left aortic arch, when you have a right aortic arch, you may have two configurations. You may have a V shape and you may have a U shape. In the two cases, you check where is the trachea. The trachea in the middle, this is the U shape or the C shape. And when the trachea, it is in the normal position. So this is towards the right of the okay. Now I would like to go to talk to you about the vascular ring. As a definition, it is an unusual congenital condition in which the anomalous configuration of the arch and their associated vessels, or both, surrounding the trachea, esophagus, forming a complete or incomplete ring around them. And these have complications like upper airway obstruction, swallowing difficulties. So, so as a definition, there should be, you will have the change in the configuration of the three vessel view. That is one important part. But you will have an abnormal vessel crossing in front or around the area. So you have this. This is the ductal arches, the ductal arch and the aortic arch. You can see the trachea is in the middle, and there is a vessel crossing this area. So this vessels which is crossing here is the one which is causing the obstruction or compression to the trachea. And that's why we need to, because if we miss these patients, they are prone to the trachea, becomes very weak. And the more it becomes very weak, their breathing abnormality is more, and hence they will need early surgery, recurrent chest infection, and they may not grow. So this is another view. You're showing the V shape. Okay, very clear. And you can see that there is a vessel going in front of the crossing between the two ductal arch and aortic arch bicolor. So this is the right aortic arch, and there is apparent left subclavian artery. Here the compression is more, because the trachea in the middle, and in front of it the left subclavian artery, and behind it is the ductal arch. So when the patient's when the child is born, then he will have what we call stridor, abnormal voice coming from the airways.
Aisha, this is interesting. Go back.
Sorry.
Just can you point to them? Where is the aortic arch? Where is the apparent left subclavian? You can slow the video.
I'll slow it. Just give me a minute. Okay.
And the presentation, actually, it is variable for the right aortic arch with apparent left subclavian artery.
So you can see easily by when scrolling.
Yeah. أيوة هو يظهر يعني بس just to point at the apparent.
Yeah. So here it will come now, this area.
Because the probe is up and the branch coming out of aorta, so it will be red.
Yes. Yeah, here it is. It's
And
red
really,
color.
yes, really you need to reduce the scale in order to see.
Yeah. So that's the red color, which is here, is the one which is we are talking about as a left, apparent left subclavian artery.
And if you Doppler, it will show you that it's an arterial Doppler, not
Not the venous.
Now regarding the presentation, Aisha, for right aortic arch with apparent left subclavian, it's very rare really to see them the presentation with the stridor, unless it's like with the diverticulum of Kummerer when the BDA remains open. So right arch, apparent left subclavian, and the BDA or the diverticulum of Kummerer. So usually these patients, Aisha maybe will elaborate like how to diagnose them further, whether we need CT or no, and what is the presentation. Because this is one of common referral we are getting.
Yeah. Actually, after birth, we would...
Sorry, Halima and Aisha, I have a question just from the antenatal point of view and counseling. I think we do get referrals with vascular ring. The patient has been already counseled that she cannot stand normal delivery and she should be delivered by cesarean with exit procedure. So please, if you just elaborate on this point, because I know that these patients they can deliver normally, as you have said, Halima. the issue of breathing difficulty and all these things, patient will be observed postnatally. But this is one point. The other point, when we refer this patient for echo for you, will you be able to say from the echo if this patient postnatally will have stridor or breathing difficulty? Um, I mean, from the echo picture and the vascular ring, if it is causing any pressure on the trachea or not, will you be able from the echo to counsel this patient about this complication that might happen post-delivery?
تفضل عائشة. I understand your question, Moza.
Yes. It's very clear. Actually, by fetal echo, it is when it is clear, it is difficult to say 100% that it is causing a compression or on the trachea or any esophagus-like. But after delivery, we can go ahead for another imaging if the echo is not that convincing, like CT angio. We can do that and then get from there well. But most of the time, if the patient remains stable after delivery and stridor is not that severe, and then no need for intervention. Intervention usually is when we have a recurrent chest infection, patient having a breathing difficulty. At that time, we intervene. Most of the time, the apparent left subclavian artery in presence in all the means doesn't need early intervention and doesn't need cesarean for the mother.
Thank you, Aisha. Yes, I agree with Aisha. Very, very rare they will have symptoms like stridor or choking. That's why for these cases, we don't jump early for CT angio. And for newborn, if we do CT angio, then they have to inject a contrast. It can cause contrast nephropathy and damage their kidneys. From echo, we can't tell right arch and aberrant left subclavian, but this is not enough. We go according to as Aisha said, the clinical presentation. Some of them later on, they can present with choking or swallowing difficulty. But as we know, the kids will start to take soft diet. This is later on. So very rare to have. For me, if I can recall for the last 10 years, maybe 2 or 3 cases who require the surgical intervention. Majority they will not need, but we'll still give them follow-up. I don't know what is your experience, Dr. Myrna, with right arch and aberrant left subclavian in terms of the surgical intervention requirement and how early you will do the CT angio. دكتورة ميرنا.
ايوه معك حليمة. طبعا I agree with you. It's very difficult sometimes to know the risk of is this a baby will have severe symptoms, respiratory symptom or not from fetal echo. Number 2, regarding the surgical, usually those cases we agree that we follow them postnatally, and we can do CT scan. I usually do CT scan for them, especially with those with double aortic arch. Just to have a baseline, and then we continue follow-up for them. Whenever they have a symptoms, we operate. Once the patient, he does not have a symptoms, usually you don't operate. So usually we counsel the family the same like this, that the patient, he will do a CT scan postnatally as a baseline, and then we keep following in the clinic. Once he have a symptoms, we'll operate. Once he doesn't have a symptoms, we'll continue just follow up him then.
And what about this case, right aortic arch, aberrant left subclavian? You will wait on, or soon you will do CT angio?
Usually, right apparent, rarely we do it. We do it mainly for those with double arch. And I think this case have some suspicion probably. I'm not sure. Looks like a one double arch, one dominant, which is the right, and possibly the left is small. But probably the image is not clear for me. I need more sweep to show it. But usually double arch, I do for them CT scan.
Actually, even like sometimes we are really in doubt. We will mention that it is double aortic arch, but postnatally when they do the CT, they tell us it's right arch and apparent left subclavian. I have some cases like this, where antenatally really it's like highly suspected double aortic arch, but turned to be right arch with apparent left subclavian. Aisha will show us very nice image of the double aortic arch.
Yeah.
Probably حليمة لأنه that's why important to do CT scan initially. So because probably بالدبل arch أحيانا يكون atretic, very atretic the other arch you are not seeing. واحيانا الducts will close so we're not able to see it. That's why احيانا better to do the CT scan as early في الفirst week of life just to show احيانا الductus, so just to show how is the effect of this right arch with the parent subclavian over with the ductus arteriosus is there.
For us, Dr. Mary, in our center, if there is like a strider and suspected double arch, we'll do it. But if there is no strider, we're stable, we bring him like 2 months, 3 months, and that time we'll do the.
I agree. Some of the consultants they do this. It's not, there is no any specific guideline, but the only guideline that is we don't operate unless there is a symptoms, and we need to counsel the family regarding this also.
And not to make the mother anxious. This is very important.
Very important. Very important.
No need for C-section. No need for C-section. Thank you, Moza, for raising this point.
Again, this is yes. لأنه مو كل right arch is again associated with apparent. ممكن يكون right arch mirror image without apparent ويكون completely normal.
Majority.
Majority, again.
Majority, yes. We'll go to the next topic, which is the vascular ring. So, and our first is about double aortic arch as a definition. Double aortic arch, the trachea and the esophagus are actually completely encircled by the aortic arch and the ductal arch. So you can see in this diaphragm, you can see the pulmonary artery and the aorta, and the aortic arch is two arches. So right one and the left one, and you can see the left one is smaller than the right one, and the trachea will be in the middle. This is the around 75% of the right aortic arch is the dominant, and usually it is isolated. Here a view of this, maybe because it is very zoomed, but you can see there is one vessel coming from here and the other vessels is coming like this. So these are the double aortic arch. We'll show you with color. Yeah, coming. So two are coming together.
So it's like zigzag shape.
Yes. Unlike the U shape, it will be a zigzag shape. So you have the V shape, the U shape, or the C shape, and this is the zigzag. Okay. So in fetal summary, this is a summary of my presentation. The three vessels and the three vessel trachea is the mandatory to study the arch sidedness and discover vascular ring. Arch sinus is in relation to the trachea. We explained when it is into the right. So this is the right aortic arch. When it is the left aortic arch. And it is very important to be familiar with the vascular ring in relation to the anatomy, position, and this will help in the early detection and intervention. So when you have a left aortic arch, and then you have a left duct, so this will be normal with normal right subclavian artery. This is not a vascular ring. When you have a left aortic arch and right duct and apparent right subclavian artery, then you think about the vascular ring. But actually, apparent right subclavian artery usually do not cause any issue unless the duct is the right side also. So, but when you have a right arch, you have a left duct, then the most important, you look to the left subclavian artery. So when you have an apparent left subclavian artery, then you think about the vascular ring. But if you have a right arch and a right duct, so whether the subclavian artery is the right subclavian artery is in the normal position or in the aberrant, so it doesn't make any issue. But when you have the arch itself is like a double, one is smaller than the other, and encircling the trachea, this is a vascular ring. So what are the vascular rings that we have? A left aortic arch with a right duct with an aberrant right subclavian artery. And right aortic arch with the left duct and aberrant left subclavian artery. And when you have a double aortic arch, these are the three important vascular ring which we look in a fetal echo. Thank you very much.
Thank you, Aisha. Very informative and very nice presentation.
Very nice.
Thanks.
So if there are any questions again, so leave it till the end. Now, Dr. Myrna will go to the last presentation about fetal arrhythmia and heart failure. Also, this is, mashallah, very important talk. Go ahead, Dr. Myrna. تفضلي.
Thank you, Halima. Come back again. Fetal arrhythmia. We need to run شوية, isn't it? الوقت is okay معانا؟ واضحة الصورة؟ واضحة البرزنتيشن؟ طلعت على الشاشة؟
واضح دكتور.
طيب we'll talk about fetal arrhythmia. We'll go practical things. يعني ما حنروح in deep details عشان everyone just have a summary so you can practice it easy. طيب in general احنا if we talk about the routine antenatal screening for any cardiac heart rhythm abnormality, sometimes not all institution, not all the department during screening, they check the heart rate. So it's very important to get your eye to get used about the normal, how is the normal heartbeat comparing with the abnormal heartbeat. So it will be easy detect for you, so you can check the heart rate and you check regularity whenever you have check by your eye. So in general, if you talk about the embryology, myocardium begin to contract initially in the 3rd week post-conception. Start the myocardium begin to contract, and 6th week we can able to detect it by Doppler. عادة. الheart is considered is the first organ usually to be لحظة لأنه معليش الصورة واضحة عندي؟
أي واضح دكتور.
اوكي.
أحسن دكتورة تعملي شير.
I'm sharing. واضح ولا مو شير؟
واضح دكتورة، واضح البرزنتيشن.
أيوه طيب yes. So okay. So عادة initially between عادة heart rate it start to be in the lower side little bit 110 between the 5 to 6 week, then start to increase at 10 week to 170, and then it will be تقريبا static من 14 week إلى تقريبا to the 3rd trimester between 150 to 130 beat per minute. لكن في early gestation the heart rate is around 110. So definition of fetal heart arrhythmia. Normal fetal heart rhythm, it should be regular, it should be atria ventricle, and it should be the heart rate range between 110 to 100 beat per minute when we measure it. Fetal arrhythmia can be slow, it can be fast, can be irregular. In general, fetal brady when it is less than 110, and tachycardia whenever the heart rate more than 100 beat per minute. It is a little bit challenging in fetal arrhythmia because we are not able to do 12-lead ECG in fetal life. So we'll try to use the fetal echo so to detect the abnormality so we can treat whatever if it is treatable or not. So we have to analyze the cardiac rhythm. Is it normal or abnormal? This is based on the record atria and the ventricle contraction simultaneous. So it should be one atria to one ventricle, followed immediately. One atria, one ventricle, one atria, one ventricle. That means it is a regular, normal fetal heart. And we have to check the heart rate should be between 110 to 180. Again, by eyeballing, you have able to detect what is it normal or abnormal. It is very clear when you see this heart fetal is normal comparing to this, which is little bit bradycardia, and this one is tachycardia. So use your eye always if you are not regularly checking the fetal heart rate, which is the normal and abnormal. The first method, this is actually by eyeballing, the first method to detect the fetal heart abnormalities. The second method is by using a two-mode M-mode assessment. An M-mode assessment by fetal echo, all we know that it can record simultaneously the atria and the ventricular wall motion, so you can able to detect a regularity of the fetal heart. However, there is some limitation, sometimes resolution, fetal position. However, it is very helpful, especially when you have a good alignment. So you put the cursor. So the cursor will, between the atria and the ventricle, sometimes alignment a little bit difficult. The most important is to have one atria, the cursor run over one atria, one ventricle. So this is here a little bit the atria, so the atria will be low and the ventricle will be higher. So atria contract, so atria will move once contraction, and the onset of the inflow Doppler, it will be appear, and the ventricle contract wall, and it will be appear in the M mode. And again, when we check the Doppler, the onset of the outflow, it appear. So again, this is very clear image more. You can see how is the cursor over the atria and over the ventricle. And the atria is here. You can see this is the hump of the atria here. Okay. And the upper one is the ventricle. This is the ventricle. So atria, ventricle. So it's a regular atria, ventricle. This is indicating how is the regularity of the fetal heart. It should be one atria to one ventricle, one atria to one ventricle. It's a very helpful, the M mode, even in case some of the arrhythmia, especially in atrial flutter, when you have 2-to-1 or 3-to-1 heart block. You can see very nice image. This is the cursor here over the atria and over the ventricle. The atria is down here, you can see, and the ventricle is here up. You can see this is the ventricle because the cursor here. And you can see one atria to one ventricle. So 2-to-1. You can see here 1, 1, 2, 1 ventricle, 2 atria to one ventricle. This is 2-to-1 atrial flutter. So M mode is helpful to detect atria and the ventricular simultaneously. And again, in some of the arrhythmia, especially with those with atrial flutter, if you have a good resolution. The third method to detect, to able to assess the fetal arrhythmia is by Doppler, especially when we have heart block or arrhythmias or tachycardias. Doppler, we can use assessing a heart rate in any of the Doppler. Once you put the Doppler over the atria, over the aortic or the pulmonary, and then you check the heart rate, this will be easy. But this Doppler is the inflow and outflow. It will help us to show again how is the ability to assess atria and the ventricle, the simultaneous regularity of the fetal heart. If we put through the inflow and the outflow, in the M mode, we put the atria and the ventricle wall motion. Here, the Doppler will show us the inflow Doppler and the outflow Doppler. We have several Doppler signal, either SVC to aortic, mitral to aortic, or pulmonary vein and the pulmonary artery. So the SVC giving indirect for the atria, and the aortic giving indirect for the ventricle. Okay, so this is the pulse Doppler. You can see this is between the mitral and the aortic. You can see the E to A. This is the mitral, and this is the spike of the aortic. And you can assess the what we call the atrioventricular conduction first. By just checking the beginning of the A to the beginning of the aortic itself. But before that, if you assess the regularity by atria ventricle, you can see atria ventricle, mitral aortic, just this is that mean indicating irregularity. The other thing, if you want to check just the heart rate, just you can put the cursor over the beginning, for example, of the aortic and the beginning aortic to aortic, and then the checking the heart rate, or between the beginning of the inflow to the beginning of the inflow, or the end of the inflow to the end of the inflow, and just checking the heart rate should be between 110, 180. But this is when we check the AV conduction is assessing to have the beginning of the atria, and this is beginning of the A and to the beginning of the ventricle. This is what we call it the AV conduction, okay, which is indirect for the PR interval on the ECG. It's helpful in those, as you know, for those with autoimmune disorder, checking the AV conduction, first degree or second degree or third degree heart block, we're checking. This is another method where the SVC and the aortic, you put the cursor, you get the sagittal view. This is the spine here, and this is anterior, and this is the superior, the heart, and this is the abdomen here down. And you can see this is the LVOT, the aortic, and the superior vena cava. Sometimes the alignment is very difficult for the SVC and the aortic flow. And usually you will detect, this is the ventricle, which is aortic here. And this is for the superior vena cava. This is the reverse flow of the venous flow of the superior vena cava. So the beginning of the reverse flow here to the beginning of the aortic. This is indicating the atrioventricular conduction. هل واضح يا جماعة ولا أنا سريعة؟
Moza, what do you think, Nihal?
It is very nice, Dr. Ma'am. Well presented.
Yeah.
Thank you.
واضحة? Okay. So this pulse Doppler through the inflow and the outflow is give me what we call the mechanical PR interval, AV interval. او اللي احنا at the ECG اللي هي اليوجوال PR interval. طبعا النمبر is different according to gestational age. There is a lot of publication they public about the number. They give the higher limit is around 140. It should be 140. Most of the normal fetuses, if you just check the AV conduction, for example, an autoimmune mother came to you, she had a risk to have a baby with complete heart block, and you are checking the AV conduction. The AV conduction here, usually, most of the time, 90 to 100, 120, but most of the literature is going between 140 to 150. For example, if you have a case showing 140, you have to go check, for example, if you are doing SVC to aortic, go check the mitral and the aortic. Do another image to be sure that it is really prolonged on all the view that you are taking it. Usually, I train with Dr. Edgar Yagi in sick kids. They usually take the cut point 155 to 160. So it's different. Most of the literature, they said 140. Experience, some of the physicians, they said between 155 to 160. But usually, if you have 140, you have to go and check another view to be sure it's prolonged.
Is to represent the PR interval, which
Yes,
is the AV interval.
But the first thing, أنا قبل ما أدخل على دي أول حاجة, the first thing you have to assess أول شيء regularity atrioventricle, بعدين assess the heart rate, the usual heart rate should be 110, 140, and usually the AV conduction. Actually, we don't, for example, for myself, I don't do it routine unless there is a risk if the mother, she's autoimmune and there is a risk that the baby might develop heart block, or if I am suspicion that there is little bit abnormality in the rhythm, so I undo it. Tissue Doppler, again, it's advanced imaging they are doing, but it's not usually practical because sometimes the fetal position is sometimes not helping me. Another method of doing assessing a fetal rhythm or fetal arrhythmia is the fetal ECG, actually. Fetal ECG, it's present in some of the centers. It's based on the signal. They average all the B-wave morphology. However, it's not routinely performed. There is a lot of problem that sometimes is difficult to distinguish between the maternal and the fetal ECG. Fetal movement sometimes may affect is the exact ECG. So it's not actually routinely can be done, and it's not able to analyze beat-to-beat analysis. Another one, fetal magnetocardiogram. Again, this is magnetic field. It's excellent, is a good to detect again a fetal arrhythmia, especially those with long QT. However, it's actually is not practical because if you can see the it's a very huge, it should be in magnetic field. Not all the center they have it. It's present in only few center in the world. How it's a very good, especially for those who have a long QT syndromes, but it's not routinely being used in every centers. So we depend on fetal echo mainly to assess the fetal rhythm. So fetal echocardiography, whenever we have fetal abnormality of fetal heart rhythm, so the first thing, assessing the fetal heart, mapping a mechanical event should be, as I mentioned, atria ventricle with a normal heart rate between 110, 180 with a regularity. So whenever we have any abnormal rhythm, we have to be sure what is the mechanism of the arrhythmia, impact on this arrhythmia on fetal circulation, if there is any association of congenital heart disease. We look for the history, maternal family history of long QT syndrome, Graves' disease, any sudden death in the family, and then we think about the option. This is, we have to put it in our mind whenever we have arrhythmia. Especially the mechanism, we have to look also for the function, fusion, valve regurg, fetal movement, all of this hemodynamic consequences can occur due to the fetal arrhythmias. Again, fetal arrhythmia need to be referred in the same day to pediatric cardiology or fetal cardiology. We don't, I always tell them, don't give her appointment. Just raise the phone for Dr. Halima or whatever. Just call me immediately that I have fetal tachycardia or fetal in the same day.
Dr. Mirna, you mean like if there is fetal tachycardia or bradycardia only, not any
not
any tachycardia or bradycardia?
Agree, yes. Right. So what is abnormal fetal heart rhythm that usually we detect? The previous slide, we know how to able to diagnose normal and abnormal rhythm. Now, what is abnormal rhythm that we have? Either abnormality in the rate or irregularity. So abnormality rate, either tachy or bradycardia. Irregularity, there is a lot, okay, either in the atria or ventricle ectomy or AV block, and we'll talk about this. So we'll talk about the most common one, which is the PAC, premature atrial contraction. Premature atrial contraction, what is a premature atrial contraction? It is a focus in the atria, okay? And it's not in the SA node. It generates an axial potential before the next schedule SA node, okay? So how I know this premature? It's always a premature. That means that there is a normal, and then you have a prematurely occur earlier, different in shape than the usual. Let's see practically. This is two types of PSC. We have a conducted and we have a non-conducted. The conducted one, you can see this is here at ventricle, and you can see this is the atria ventricle, and there is another one, atria come prematurely, not like the usual, the previous one, okay? And even the ventricle, because it's conducted to the ventricle, it's also with abnormal shape comparing to the previous one. This is what we call a non-conducted premature atrial contraction. A non-conducted premature, actually, see, this is the atria came prematurely, however, it's not conducted in the ventricle and there is a pause, okay? And then retain back to the normal. So this is what we call it, the non-conducted premature atrial contraction. If we go back, in general, PAC is the most common of the referral, 90%. It's present around 1 to 2% of the pregnancy. Some of them, they said the causes, it is redundancy in the septum primum. It can be intermittent, can be regular. As I mentioned, can be conducted, can be not conducted. Most of the time, it's a benign. There's a benign things. There is no treatment required, only need a follow-up. Okay, you need just follow for the biophysical profile, follow up. Sometimes it's continue to the end of the pregnancy. Sometimes it's a short-lived and finish quickly. So more than 50% of the fetus actually referred with a history of skip beat will have a normal echocardiogram hour 2 days later. A very low percentage, 1 to 2%, they might develop in supraventricular tachycardia, especially those with the blocked PACs. They may have a little bit risk to have, especially those with atrial bigeminy. They have a low risk of supraventricular, so they just need a biophysical profile assessment, weekly heart assessment, heart rate assessment, just to be sure that it is continue or it is resolved and it's not progressed to supraventricular tachycardia. And we need to reassure the mother that it's a benign thing and it doesn't need any treatment. Sometimes blocked PACs is little bit have some difficulty in especially between the second degree and the blocked PAC, because the blocked PAC الهارت ريت حق الفيتس عادة يكون 80 okay, between 80, sometimes 90, sometimes a little bit difficult to differentiate it between a second-degree heart block and the blocked BAC. Second degree, they have a regular atrial rate rather than a blocked BACs where you have a premature atrial beat is there. However, it's a little bit difficult, especially if you don't have a good image to detect it. Then we'll go to fetal tachycardia. Fetal tachycardia, this is an emergency. Whenever you have fetal tachycardia, you have to refer it on the same day. Ventricular rate more than 180. And it can be intermittent or sustained. And what we mean we sustain, that it continue more than 50% of the time, or while you are scanning the mother, 50% of your time of scanning, this tachycardia is present. This is what we mean by innocence or sustain. Or it's made more than 12 hours per day, or sometimes if you hook the mother and assist her heart rate, her fetal heart. The most common type of fetal tachycardia, alhamdulillah, ده اللي هي benign one, اللي هي AVRT. This is the most common one. It's about 66 to 90%. The other little bit atrial flutter can be present in about 10 to 30%. There is other type of tachycardia like sinus tachycardia. For example, you have atrioventricle. Atrioventricle, however, the heart rate is around 180. Sometimes you need to check the mother thyroid. Anemia, sometimes it can cause. Other type of fetal tachycardia is little bit very rare, which is VTAC, and atrial fibrillation is very rare to have it. So as I said, it can be, you assess the AV relationship. It can be 1-to-1, less than 1-to-1, more than 1. More than 1-to-1, as I showed in the previous image, which is the atrial flutter, when you have 2 atria, 3 atria to 1 ventricle. 2-to-1, 2 atria to 1 ventricle. This is atrial flutter, and usually present in late gestation, between more than 30 weeks, and it's very easy to treat it. If the mother presents to you more than 35, sometimes you deliver her. Usually 1-to-1, usually we have to assess the interval, and we'll come to this. Most of the common, it is the AVRT, supraventricular tachycardia. This is the most common one. Usually they have short VA. I will show you how is it. The other one is a little bit complicated, and it's very difficult to treat. VTAC is very rare to have it. Most of the time we have AVRT and atrial flutter. Supraventricular tachycardia, it's 1-to-1 AV conduction, 1 atria to 1 ventricle. However, the heart rate will be more than 250. Either, as I mentioned, persistent or intermittent. Most of the time, it is several types of supraventricular, but the most common is AVRT, 90%. How to diagnose it? To have a short VA interval. I will show you how that's the meaning by short VA. There is the conduction. What is my mean by AVRT? That means there is normal conduction through the SA node from the atria to ventricle. However, there is a retrograde conduction, or what we call accessory pathway, retain back and continue to firing the atria, causing this supraventricular tachycardia. As I mentioned, 90% is AVRT. 10% they have a long VA. What we call the automatic ectopic atrial tachycardia. This is the heart rate between 210, appear early in gestation. This is the one which is very difficult to treat, and usually you give her several medication and there is no response. However, AVRT, once you give her the antiarrhythmic, immediately they will respond. What I mean by short VA or long VA, this is what we call by short. When we put, again, the inflow to the outflow Doppler by the mitral aortic or the SVC aortic, and we'll check where is the VA and the AV. Short VA, that means you can see how is the short. This is the ventricle, and this is the atria. The distance here, short VA, they are shorter than the AV. See, if the distance between the atria and the ventricle is longer, here the distance between the ventricle and the atrial, it is shorter. That means this is what we call it short VA or supraventricular tachycardia. Atrial flutter, as I mentioned, it's appear late in gestation, 33 weeks, and 2-to-1 or 3-to-1. That means the atrial rate is doubling the ventricular rate. As I said, it appear late and very well respond to antiarrhythmic medication. As I mentioned, this is the same image. Management, urgent. Okay, there is a 3 approach to management. Either to give her antiarrhythmic medication or delivery if she's more than 35 or 37 week deliver. However, no premature delivery wherever for the mother, if she came before 35 week, we don't premature delivery. We can give her a chance of antiarrhythmic medication and need to have an urgent referral on the same day. There are several things you have to choose before you think of delivery, gestational age, lung maturity, all of this. Can you think about it before you planning for any delivery? Any mother with fetal tachycardia and you are planning to have antiarrhythmic medication, you have to admit the mother, you have to consult adult cardiology, electrophysiology. I have to do also 24-hour Holter to the mother, electrolyte to check her before starting any antiarrhythmic medication. In the literature, there is a lot of protocol about treating those cases. However, usually most of them, usually whenever we have a sustained tachycardia without high drops, if it is more than 35-week gestation, usually we deliver her. If it is 36 or 37, we choose to deliver. If it's less than 35 weeks, usually start antiarrhythmic medication. There is a lot of choice for antiarrhythmic medication, sotalol or flecainide or digoxin. When we have a sustained tachycardia with high drops, usually we have to have dual medication, flecainide usually plus oral digoxin. If there is no response more than 5 days, usually replace digoxin to sotalol. If there is no response, you have to have a direct amiodarone through the umbilical vein, this is a very invasive procedure. And usually when we reach to this, that indicate that we are not dealing with AVRT, we're dealing with the more complex arrhythmia patients. Usually, most of the time, most of the literature, they said for those with supraventricular tachycardia, the best is flecainide, to start with the flecainide. Flecainide, we can starting dose around 100 milligram Q8 hourly, and there is a level. We have to do a daily, we have to keep the mother the first 3 days after the last dose change. And we have to look for the ECG for QT, for any other complication. It have a little bit nausea, visual disturbance sometimes. Sotalol, I love the sotalol, 160 milligram PID. Again, we do maternal ECG for the first 3 days. And again, we look for the ECG for any QT prolongation or any bradycardia or dizziness. Digoxin, we have to be careful in digoxin, especially the absorption is when the fetus is hydropic. The success rate in hydropic fetus is only 19% comparing to non-hydropic 63%. So in hydropic fetuses, some of them, I don't like to use it. However, in the literature, they said you can use flecainide plus digoxin in hydropic fetus. If no response, you replace it with the sotalol. This is a nice review article. This has been published in Circulation 2011. They compare the transplacental treatment of fetus with SVT with digoxin, flecainide, and sotalol. And what they found that the sotalol has a very good highest rate for prenatal atrial flutter termination. Whenever you have atrial flutter, you have to use sotalol. Comparing to flecainide and digoxin, it is very good for those with supraventricular tachycardia. So the first line, flecainide or digoxin, considered the first to treat significant fetal tachyarrhythmia like supraventricular tachycardia, and they didn't find any serious fetal or maternal drug adverse event observed. Several cases, a lot of cases this is a case of tachycardia. This is a case of atrial flutter. Just to show you this case of intermittent fetal SVT. You can see return back to normal and go back again, tachycardic. I saw it only once in my life. I didn't see any case intermittent. All the cases that I saw is persistent. Usually these cases, whenever you have intermittent tachycardia, you keep observe the mother weekly. Once function is good, no valve regurg, no any sign of high drops, like this mother, she reached to term and without any problem and deliver normally. And we didn't start her on any arrhythmia medication. So you have to weigh and observe very close follow-up to be sure that is not progress to any high drops. This is a case, you can see supraventricular tachycardia start to have a hydropscan. It was early in gestation, around 24, what I remember. Once we started, at that time, we started in the sotalol and became immediately resolved. This is another one. You can see severely hydrops, fetuses, and unfortunately, we do all the medication, even the invasive amiodarone, and unfortunately the fetus did not respond and die entire time. So we'll go to the next, which is fetal bradyarrhythmia. It's less than 110. The most common, 60%, whenever you have fetal bradycardia, you have to rule out sinus brady first. But however, the most common, it's complete AV block in more than 60% of the cases. The other way, when we have a 1-to-1 AV conduction, however, the heart rate is less than 110, usually this is what we call sinus brady. And sinus brady, usually the heart rate of sinus brady is 80, 90 beats per minute. Never, very rarely to have a sinus bradycardia with heart rate of 50 or 40. Whenever you have a heart rate of 50 or 40, this is a complete heart block. So sinus brady, 1-to-1 AV conduction, heart rate between 80, 90. There are several causes. One of the most important causes, you need a follow-up for these cases. They might have prolonged QT later on. You can see this is a sinus. You have a regular atria-ventricle. However, the heart rate is slow at 84 beats per minute. Heart block, we have 3 types. We have the first degree, second degree, third degree. First degree, how we can diagnose it when we have a long AV interval. If you remember mechanical PR interval, when we measure it, anything above 140, that means indicating this is a prolonged. Once you have a more than 140, more than one images, that indicate that there is a first degree heart block, especially when those autoimmune mothers. Second degree, when you have, again, heart block slow, and there is 2-to-1, we'll show it to you. Or a third degree complete heart block, when there is a complete dissociation between the atria and the ventricle, and usually the heart rate is 40 to 70 beats per minute. In general, AV block, heart block in general, we have 2 types, either heart block with a structural heart disease or heart block with a normal heart. Like in the autoimmune disorder, Sjogren, SLE syndrome, or they have positive antibody. And especially if it's second degree ARB block, you have to rule out what we have a long QT syndrome. However, we cannot diagnose long QT syndrome, and we cannot assess the QT syndrome in fetal echo. We have to do fetal magnetocardiogram, which is not available in every center. So we have to wait some time postnatally to diagnose it. It is very clear how you see fetuses with fetal bradycardia. This is a case of fetal heart block here, you can see. And you can see this is the cursor in mode. You can see this is the atria, and this is the ventricle. You can see one atria, and this is ventricle here, and then atria, ventricle. So it's a dissociation, sometimes coming 3 atria or 2 atria, or so it's completely dissociation between the atria and the ventricle, and usually the heart rate is 40 to 50. See here, this is a heart rate of 40. This is atria, and you can see the ventricle. This is the atria, and again you can see the ventricle here. So it's completely dissociation between atria and ventricle. This is what we call complete heart block. Management. When you have, we'll talk about the heart block due to autoimmune disorder. If, for example, the mother, she had a positive antibody and you are following her and the baby had a complete heart block, we'll talk about the management of those cases. Hydroxychloroquine is very important. Whenever you have a mother with autoimmune and positive antibody, you have to refer her to rheumatology, and they have to start even hydroxychloroquine, because it's been proof that it is the first prevention if given, especially before the 10th week of gestation. It's reduced the recurrence of 50%, especially if the mother had a previous baby with a heart block. So those cardiology, when you have a mother or she had a previous baby, you need to refer her to the rheumatology to they start them on hydroxychloroquine to prevent a recurrence. Other management, there is a lot in the literature about it. For example, this is a recent publication, 2023. They have expert consensus statement on the management of the arrhythmia during pregnancy for the mother and the fetus. It's nice to review it. They talk about all the previous management. Let's talk about dexamethasone. Dexamethasone, what they mentioned that it is in the literature, they demonstrate a variable result in the efficacy of the antenatal steroid for the treatment of fetal heart block. Before, we were using dexamethasone to, especially for those heart block, we think that steroid can prevent or can reverse the heart block, which is not. You cannot reverse. Once the fetus have a fetal heart block, they cannot able reverse to be reversed, because sometimes they develop heart block in hours. So it's not. Regarding the efficacy, it's different. They have variable result. And in the current literature, they report steroid treatment for isoimmune heart block is non-randomized and underpowered, because they have a lot of fetal complication like growth restriction and oligohydramnios. So it's not actually being used as regular for those with, once the mother have a heart block for the fetus. Again, as I mentioned, third degree heart block has not been demonstrated to be reversed. Once you have the fetus have a heart block, he cannot be reversed back to second or a first degree. First or second degree might possibly be reversed or slow the progression. It might be reversed. However, third degree cannot be never. I never saw second degree be reversed to first degree. Might be some of the cases, but I never saw it before. Because second degree heart block sometimes is very difficult to differentiate it between second degree and blocked PACs. Because a lot of cases that been diagnosed as second degree heart block postnatally turn to be blocked PACs. So you need to be sure about the diagnosis before that we label it. So in general, dexamethasone, it cannot be reversed. Some of the publication they mentioned, like in Cobel in 1995, they mentioned that the improvement in the degree of the AV block, but cannot be reversed. They can improve the contractility by diminishing myocardial inflammation, reduction of the effusion by inhibiting general inflammation. However, as I mentioned in the new publication, they mentioned there is a lot of side effects, so there is no significant strong evidence to use steroid for those mothers with heart block. Immunoglobulin, again, a treatment for those. Immunoglobulin is sometimes treated again for those with autoimmune antibody-mediated cardiomyopathy. Once you have a heart block with decreased function, a lot of endocardial fibroelastosis, thickness, some in the literature, they suggest to use IV immunoglobulin with a steroid. It might help to improve the outcome. But again, IV immunoglobulin still have a lot of complication, the induction, infection, hypersensitivity. Again, the data regarding the timing, the doses is still limited. So using of these things need to have a multidisciplinary team. It's not a regular treatment that can use. This is again publication in arthritis, and this is an important one. They have evaluated fetus in preventing IV immunoglobulin therapy for congenital heart block. They use the dose of 400 milligram per kg on tri-weekly schedule from 12 week to 24 week of gestation. They found is ineffective as prevention of heart block. So even if you use IV immunoglobulin to prevent the heart block, is not effective to prevent the heart block in pregnancy at a risk of recurrence. Beta blocker, sometimes they use it when the heart rate below 40. They can little bit increase the heart rate, but again, beta blocker still have a lot of maternal complication, pulmonary edema, electrolyte imbalance, maternal cardiac dysfunction. And again, personally, I use it. They increase the heart rate of 1 or 2 beats, so it's not of benefit. For example, heart rate of usually below 50, sometimes we use it, but it will increase only 1 or 2 beats. Salbutamol or terbutaline, it sometimes increase the ventricular rate. It improves cardiac function. However, still there is a lot of complication about it. This is a case, you can see here the heart rate was 46 using after a beta blocker is increased a little bit to 55. It might help a little bit increasing the heart rate, but it does not increase it higher than this. So in general management of immune-mediated heart block, you have to have a weekly fetal echo assessment for the ventricle and atrial rate. You have to assess if there is any involvement of the myocardial disease, endocardial fibrosis, any AV valve insufficiency, amniotic fluid. Also check the heart rate. If it is more than 55 or less than 55, more than 55, this is a good prognosis. Those once less than 40, that means indicating they have a poor prognosis. Risk of mortality is 19%. Risk increase once you have more EFE, more decreased function, especially if we diagnose it less than 20 weeks, or if the heart rate, as I mentioned, less than 55. That means there is a very high risk of mortality for these cases. Before I end, I talked just about heart block with immune-mediated. For heart block with a structurally abnormal heart, for example, like isomeric heart, or congenitally corrected TGA. Those fetuses, once you have heart block, especially with isomeric heart, left isomerism or right isomerism, usually we don't start them anything. We just keep observing. And usually most of these cases, they have a very poor prognosis, and usually they die intrauterine. So you just keep following them and follow their Doppler and venous Doppler and assess them. And you have to mention that the mother, the risk will be very high for mortality once, especially if they develop hydrops. Thank you very much.
Thank you, Dr. A very informative presentation. So by now we reached the end of our webinar. If there are any questions from the participants.
Question can be right in the chat, Doctora.
Yes, I open till now, no question.
I just have a question, Halima. Do you hear me?
Yes, تفضلي موزة.
Yeah, this question to Dr. Manna regarding how to differentiate between premature atrial contraction and the ventricular one.
Between الBAC والبlocked BAC or إيش موزة again
أيوة,
question.
yes.
You
Dr.
mean between blocked PACs and
if it is blocked or not blocked. دكتور ممكن تروحي للسلايد هذيك
ايوه خليني ارجع لك السلايد معليه. انا شيرنج ولا من شيرنج؟
بعد رجعي لان انت الحين وصلتي لل
اي دقيقه ادخل افتحها. معليش ما ادري ليش قفلتها انا. Okay, here. So the premature atrial contraction, let me go to exactly the slide, you know. Okay. You will have normal, regular atrioventricle flow Doppler. However, it will have a prematurely atrial contraction. هنا قبل, sorry. Sorry. No. Yeah, here. This is very nice. See between the premature atrial contraction, you will have a normal atrioventricle, and then there is another beat coming, which is coming earlier. You can see the atrial here comparing to the atrial. It's coming earlier, and the ventricle, even it's come conducted. However, it's a smaller or different shape than the previous one. Okay, and you can see little bit pause after it. This is how to, and then return back to normal. This is the simple way how to differentiate between a premature atrial conduction, the conducted. The non-conducted is still, you will see a prematurely, however, is not conducted. Okay, and even when you check the heart rate here, you check the heart rate is regular, the ventricle rate is regular. However, the atrial rate here is still, because coming prematurely, it's becoming a little bit irregular and then return back to be normal. هل واضحة ولا؟
أيوة واضحة دكتورة. But I mean regarding the outcome, I mean most of the premature atrial contraction, they doesn't have effect on the fetus, yes?
Okay.
Whether it is conducted or not conducted.
ماني
She
سامعة
means,
صوتها.
she means whether it's a benign condition to reassure the mother or a risk of
It's all of them benign. There is no treatment. You just need a follow-up for their biophysical profile, checking her fetal heart. However, there is still risk, about 1 to 2% risk to develop supraventricular tachycardia, especially for those with the non-conducted.
أيوة, it is clear now, yes. Thank you.
Welcome.
Usually determine like by third trimester, usually if they will have 1 to 2%.
Yes. But still, I keep following, يعني will follow them. I don't follow them. Even the MFM team, they follow them just to, if they have any tachycardia, they notice, they return it back to me.
Yeah.
But most of the time we reassure the mother.
And usually the follow-up every how many? Every 4 weeks or
Weekly,
how
actually.
frequent you will?
والله it's عادة bi-weekly.
Bi-weekly.
Yes. يعني كل أسبوعين تقريبا.
Okay.
للBACs حتى دكتورة ميرنا؟
Yes. أنتوا قد إيش؟
أنا والله إذا ما أرجعها
البلوكت لا أنا أتكلم على البلوكت حليمة. أنا ما أتكلم على الكوندكتد، أتكلم على النون كوندكتد BACs.
مثلا 4 weeks ما أخليهم like so you bring them twice per week.
لا every 2 weeks.
2 weeks. Okay.
Yeah.
اللي هو non-conducted.
Non-conducted
one.
Well, conducted, I reassure them. I refer them back to my colleague, the obstetric team, and they just keep following them with their biophysical profile, and you will see. Even if you see an skipped beat, it's nothing.
Yeah. Because most of the time, actually, we reassure them, and I mean, in the fetal medicine, we don't. We just reassure them, and they follow up with their parents.
Yes. It's different, يعني.
Any other question يا جماعة الخير سواء للفيتال أريثميا أو الرينج أو indications. Still in the QA, no questions.
يعني انتوا ياهم they are they understand all the lecture ولا؟
لا انتوا ما شاء الله عليكم. The presentation was very clear and
طيب
well
الحمد لله.
presented. ما شاء الله يعني it was informative webinar from all of you. Thank you.
Alhamdulillah. And these presentations will be recorded, so even if you want to watch it again, so it will be more يعني
Excellent.
Thank you very much. So by this, we reach the end of the webinar. I would like to ask our dear valued guest, Dr. Myrna Atiya from Prince Sultan Cardiac Center and Dr. Aisha from Sultan Qaboos Hospital. I enjoyed really the session, and thank you to all participants. Hope to see you again in another webinar بإذن ta'ala. Thank you so much and have a good night.
Thank you very much. شكرا حليمة. Thank you.
very much.
Thanks a lot, Zakiya, for the organization and for all panelists, Dr. Moza, Dr. Nihal, and the rest of the group for the support.
Thank you for all of you. شكرا لكم.
Thank you everybody.
شكرا. مع السلامة.
مع السلامة.
ليلة سعيدة دكتورة. مع السلامة.
مع السلامة.